let's start, okay? Yeah, so it's a fairly large organ. So it's not only a fairly large organ, but it gets a fairly large share of the cardiac output too. So it was kind of an even distribution. So urea, uric acid, those are excreted mainly through the kidneys, of course. Those are water-soluble substances. And iron is lost mostly through the skin, by losing cells from the skin, okay? So that leaves us with copper. Yeah, so bilirubin gets conjugated with glucuronic acid, not with bile acids, with glucuronic acid. And the reason for this is we want to make it more water soluble. So that's what the liver does. Okay, so let's see. Okay, I have more questions for you. Most of you guessed it right. So it's renal failure, bleeding, coma. Those can all be caused by liver failure. So let's see who is leading. Kira is leading again, but I have lots of other questions for you. So we can have a look at the slides now. So today we are going to have the liver, which is a very important organ. And today we are going to have these beautiful birds, okay? So what's the significance of the liver? So it's not only a large organ, but it's an organ that we cannot live without. So it's vitally important. And as we have seen, it gets a really large share of the cardiac output. That's much larger than what is necessary for survival. Now, from this, it is evident that liver has a very similar role to the kidneys, that is to screen the blood, and obviously to have an opportunity to excrete whatever we think is not really necessary. But the liver also produces, of course, the bile. So for this reason, many people believe the liver is really a part of the digestive system, which it is truly. But I think this is not really true, really, because the liver is I think it's even more important from the point of view of biochemistry. So I would say it's the central organ of biochemistry. We have a lot of material that is only synthesized in the liver. Lots of materials are excreted by the liver. And what is even more important, lots of materials are transformed by the liver. Now, this transformation, which we could call biotransformation, is sometimes called detoxification. But this is not really right, because it kind of gives the idea that the liver has some kind of intelligence, and it can tell which materials are toxic for the body, and sort of detoxify these things. But this is not true, as we are going to see. And the liver can also store some nutrients, as we are going to see that a little bit later. So this is just a reminder for you what is the structure of the liver. And when you study the microscopic structure and the macroscopic structure of the liver, you will realize that it's really truly an organ that was designed to filter the blood. So the liver cells, they form these large sheets, and the blood flows parallel to those sheets. And the liver cells form these hexagonal structures, and the blood flows from the outside towards the center. And this way, the cells that are towards the outside, those are oxygenated the best. So this is called zone one. So here, oxygenation is good. And here, usually, we see those metabolic processes that need a lot of oxygen, a lot of energy. So here we usually have gluconeogenesis. Here is where the urea cycle goes on, and this is a place which is sensitive to direct toxins. Now there we have an intermediate zone, and there is zone 3, which is near the central vein. Here the oxygenation is not so good, and here we have metabolic processes which need perhaps less oxygen, perhaps less energy. So here we have glycolysis, lipogenesis, and this part is sensitive to secondary toxins. Now, what are those secondary toxins? That sounds a bit funny, strange. Now, secondary toxins are toxins that are produced by the liver itself. So, as I told you before, the liver doesn't really have an intelligence. It cannot tell which materials are really toxic. So sometimes what happens is that in the first zone, a relatively less toxic material is turned into a more toxic material, and that is what we call a secondary toxin. And the central zone is more sensitive to those secondary toxins. And of course, because of the pressure circumstances, this is this is the area which is mostly sensitive to circulatory problems and biliary obstruction. Okay, so here we see the structure of the liver in more detail. So as you can see, between those sheets of liver cells, on both sides, we have the capillaries, which are called sinusoids this time. The name, we use a different name just to emphasize the fact that sinusoids have even more fenestrations than usually capillaries do, and that means that the blood that flows here can very easily get into the space of Dissa, which is basically the interstitial fluid. And as you can see, the liver cells that have contact with the space of Dissa have a really large surface. So there is a very easy exchange of materials between the space of Dissa and the liver cells. Now, the liver cells are so-called polarized cells, which means that the membrane that is between the liver cells is very, very different from the membrane that is towards the sinusoids. So here we have the bile ducts. So when bile is getting formed, the bile is excreted into these bile ducts, and the bile ducts are separated from the space of this by tight junctions. So normally, because the tight junctions really closely closely stop any kind of flow between the bile ducts and the space of this. For this reason, under normal circumstances, no bile is able to flow back into the space of this. Now, of course, this is different when we have um, inflammation and these tight junctions are damaged, or when we have an increase in the pressure in the bile ducts, then these tight junctions can open up. And that's the time when some bile can flow back to the space of this. Now, as you can see in this picture, within the sinusoids, there are lots of macrophages. And these macrophages this time are called Kupffer cells. And according to some estimates, 80% of all tissue macrophages are actually here. So that suggests that the liver is a major organ of the reticuloendothelial system and actually plays a role in the immune defense of our body against infective agents. So this filter function gives us basically three possibilities. Um, it is possible to filtrate the blood that comes from the splanchnic area. And this filtration makes it possible that the liver can also filter infective agents that might escape through the bowel and get to the vena portae. So that's the immunologic function that I mentioned before. And what is the proof for this? The proof for this is the existence of a disease which is called spontaneous bacterial peritonitis. This is a disease which is called spontaneous bacterial peritonitis because there is no obvious reason for the bacterial infection of the ascites fluid, because that's what it is. When in Usually this disease is found in advanced liver failure, and the disease is that in the ascites fluid people can find bacteria, and they have no idea where the bacteria came from. So that's why this disease is called spontaneous bacterial peritonitis. And this disease is usually seen in patients who have an advanced liver disease with a significant amount of ascites production. And from this, we can conclude that yes, normally there's a protection against microbes that the liver provides us with. Okay, and of course, there's this biotransformation that I also mentioned. So there's theoretically, the liver is capable of detoxifying the stuff that comes directly from the gastrointestinal tract. But as I told you, this is kind of this is not an intelligent operation. This is more of a constant um, operation that happens um, to most of the materials that not actually not regarding whether if it's a toxic or non-toxic thing. So we are going to study this biotransformation in a moment. Okay. And there's a possibility of temporary storage of materials. So we know very well that the liver takes up a lot of sugar and produces glycogen out of it. So this is a temporary storage place for carbohydrates. And also the liver contains lots of amino acids and proteins. So when after the fats state in the postprandial state, a lot of amino acids are taken up by the liver, and the liver can produce all kinds of proteins out of it. So it acts as a temporary storage place for materials. And it's mentioned that this is not true for lipids. I want to point it out that lipids are dealt in a very different way. So when lipids are absorbed through the gut, instead of getting directly into the bloodstream, they get into the lymphoid system. So this way, the chylomicrons, which are produced in the gut cells, they kind of avoid going through the liver. So they go directly they go directly to the systemic circulation. And of course, it can filter systemic blood as well. So not only the blood that comes from the splanchnic blood. The liver can also filtrate this systemic blood. And this way, it has a capability of excrete materials into the blood. That's what happens during fasting. So this is how the glycogen degradation can provide us with glucose when we are fasting. Uh, we can synthesize materials that get to the blood. So, for instance, blood clotting factors are synthesized mostly in the liver and they go into the blood this way. And as I told you, it's the central organ of biochemistry. And there are some nutrients, iron, and vitamins, which are also stored in the liver. So, what is this biotransformation that I mentioned to you? So, this is kind of a stereotype reaction. So, the reaction is pretty similar to all materials, and the goal of this usually to increase the polarity of those materials which are apolar. So there is kind of a division of labor between the kidneys and the liver. The kidneys are excellent. Both, no, first of all, both of these organs are excretory organs. But the kidneys are excellent in excreting water soluble substances. The liver can excrete not so much water soluble substances like cholesterol, for instance, through the bile. But the liver can kind of help the kidneys by making not water soluble apolar substances into more polar, more water soluble substances. And actually, that's what's happening. So you can see a nice division of labor between the two organs. And once substances are more water soluble, then the kidneys have a better chance of excreting them. So that's why we have this biotransformation. It has two steps. As you can see, there is a step one, which is kind of an activation. So this could be lots of things. It could be oxidation or reduction or hydroxylation, and it usually occurs with the help of the cytochrome P450. And this only activates the substance. So this only helps the substance to enter further reactions. And it's the second phase, the further reaction, which actually makes it more polar. So normally these two phases are in sync. So if one of them is getting faster, then the other one is getting faster as well. Now, why is this important? Because if these two phases are not in sync anymore, and this is what happens in alcoholic people. In alcoholic people, the first phase is increased because in alcoholic people, there's an induction of the cytochrome P450 system. So the first phase reaction gets faster, but the second phase reaction is not, because usually also there's a toxic effect of alcohol on the liver. So for this reason, what happens is that these activated substances will accumulate, and this accumulation of the activated substances is very problematic because these activated substances are very eager to react with other molecules. And if they cannot, they might react to molecules that they actually should not react with. And that means they can damage the liver itself. So this is what happens in alcoholic people, and that's why the liver is especially sensitive to the toxic effect of alcohol. Okay, so what are the metabolic consequences of liver diseases? We can look at different components. So, what are the consequences on carbohydrates? Now, of course, during the postprandial state, the liver may not take up so much glucose, and that means more glucose can get to the systemic circulation. So, in a postprandial period, we might see hyperglycemia compared to normal. But after prolonged fasting, especially in alcoholics, we might see also hypoglycemia. Why? Because after the postprandial period, so in the fasting state, in the long-standing fasting state, it's the glycogen stores that give you glucose, or if the glycogen stores have already run out, then it's gluconeogenesis, which gives you glucose. And in alcoholic people, gluconeogenesis is inhibited. And that's the reason why in alcoholic people, after prolonged fasting, hypoglycemia may occur. Okay, what happens to proteins? As I told you, so many proteins are produced in the liver, and of course, we are going to see a lack of those proteins. So usually we see this in long-standing advanced liver disease. In these cases, we expect to see low albumin and less clotting factors. And on the long run, if the liver problem is very advanced, then hepatic coma or encephalopathic coma may develop as well. The lipids, if the liver is, in case of a liver failure, um, the liver, so what kind of problems we may have in connection with lipids? The liver is very sensitive to an overload of free fatty acids, and whenever there is an overload of free fatty acids, then the liver can become fatty very easily. And the fatty liver is a problem because fats are especially cause an environment in which peroxidation is very easy, and that can cause further inflammatory reaction within the liver. So as we are going to see, especially in alcoholic damages to the liver, first we are going to see a fatty liver, which can turn into an inflammatory state, and that can get worse. And it is very important to see that there's a decrease of catabolic and excretory function. There are many drugs that are metabolized through the liver. And that's why in liver disease, in alcoholic people, many drugs may easily become toxic that at a dose which is not toxic to healthy people. Also, in advanced liver disease, there is a decreased, there's an altered metabolism of steroid hormones, and that leads to an accumulation of estrogens, and that's why gynecomastia occurs usually in alcoholic people. So let's see the clinical signs of liver diseases. Now, these clinical signs are quite variable, and I try to list them in increasing order of severity. So usually liver diseases, so for instance, an hepatitis, usually is accompanied by nausea, having a temperature, and fatigue. But as you can see, these symptoms are very non-specific. So they are you can have these symptoms for so many reasons. So if someone has these symptoms Usually, neither the patient nor the doctor really thinks of a liver problem first. Okay, now what else? What other signs we have? During physical examination, the liver may become palpable. The liver may be tender. Splenomegaly can develop. Sometimes we see jaundice. Uh, Many times people develop palmar erythema. They may have spider nevi, excoriations on the skin, and loss of body hair. There is this thing called fetor hepatis, which is a kind of musky odor that some people have with advanced liver disease. We may see symptoms of portal hypertension, which is ascites formation, caput medusae, and esophageal varices. I'm going to show you a bit later on pictures of these things. If the liver disease is an advanced one, then we may see a bleeding tendency, and at the end, confusion and coma may develop as well. There are several links in the material, so if you click on the links, you can also see pictures or videos of these things. So let's see the classification of liver diseases. Usually we talk about hepatocellular or parenchymal liver diseases. And of course, there are lots of hepatobiliary diseases in which there is an obstruction of the biliary tract. These are called cholestatic diseases. And there are a bunch of other diseases in which primarily the vasculatory portion of the liver is damaged first. Now, we don't have time to go through all of the diseases, so we are going to concentrate on the most important ones, and those are the parenchymal ones. Now, parenchymal liver diseases can be different. So we may have an acute liver injury, and most of the acute liver injuries are healing because the liver has a fairly large capacity for regeneration. So the liver can survive major, inflammations. But in certain patients, the acute liver injury is so significant that they die during the acute phase of the liver injury. Now, this is called atrophia hepatis flava. If the patient survives, sometimes the inflammation in the liver becomes chronic. So this is called chronic hepatitis. And sometimes chronic hepatitis turns into a further process in which the chronic hepatitis causes a continuous reconstruction of the liver with an accumulation of collagen fibers, which is called cirrhosis. So we are going to go through these items. So let's see first the parenchymal liver diseases. They can be acquired or congenital. Um, we don't have time to look at the congenital ones, but you can see um, they are the inherited hyperbilirubinemias, and there are some other genetic syndromes. Hemochromatosis is pretty common. Wilson's disease is kind of a rare disease, but both of them on the long run damage the liver significantly. They are not primarily liver diseases, but the accumulation of iron in the case of hemochromatosis or copper in the case of Wilson's disease will damage the liver on the long run. So let's see the acquired parenchymal liver diseases. They are usually caused by toxic effects, infections, or an autoimmune reaction. So let's see first the toxic effects. Toxic effects can be due to many, many things. Number one in Europe is alcohol, but also there's a lot of mushroom poisoning and drugs can also damage the liver. Okay, so since we have birds today, I'm showing you these blue foodies, boobies. Those have really nice blue legs, and they live in Galapagos Island. Yeah, I have a case study for you, so pay attention because we are going to have some Kahoot questions in connection with this case. So there's this 32-year-old man who gathered and ate mushrooms. Gathering and eating mushrooms is very healthy, by the way, but you want to be careful with them. So 8 hours later, he developed vomiting and profuse diarrhea. On admission, which is 20 hours after the ingestion of mushrooms, he was dehydrated. ASAT, bilirubin were mildly increased, prothrombin time was normal, and the therapy was IV fluids, penicillin, oral and acetylcysteine, and oral activated charcoal. By the second day, diarrhea resolved. So that seems to be good news. Maybe the patient is healing. But unfortunately, ASAT and PT prothrombin time continued to increase. On day 3, ASAT was 2,400 units per liter. ALAT was 4,100 units per liter. The upper limit of normal is 50. And prothrombin time was greater than 60 seconds when the normal is about 12. And total bilirubin was 11 milligram per deciliter, which in conventional units, it should be less than 1. On day 6, ASAT seems to significantly improve. So it went down to 355. So that's an improvement. But the total bilirubin level went even higher to 16. There was a metabolic acidosis, hypotension. And on the 7th day, hepatic coma developed, renal failure developed, and ARDS developed. And on the 9th day, the patient actually died. So this is a real case, okay? So if you want to study the case in more detail, you can click on this link and you can see it. Okay, so let's continue the Kahoot. Okay, so let's see the Kahoot now. So many of you answered correctly. So this is a good example that sometimes improvement in laboratory signs is cannot be considered a real clinical improvement. So the problem here was that actually bilirubin was even worse. So that actually showed that the situation is just getting worse. And in this case, the enzyme level is getting lower simply because there are fewer viable liver tissue left that by dying releases the enzyme. Okay, good. Peach is leading, Kira is second. That's a very famous, very poisonous mushroom called the death cap. Yeah. It's the amanitin that is really fatal. We are going to see it in a moment. Okay, so Osalari is leading, but now we are going to have a pause and we are going to return to the Kahoot a bit later. So, okay, so it's death cap. Oh my God. What happened? for some reason, I sorry that the next question also started. So we lost one question, but anyway, we have lots of others. So the death cap, okay, so it has several toxins. It has the phalloidin one, which is responsible for the GI effects, but it's a mild toxin, so that's not the real problem. It's the amanitin, which is actually an mRNA synthesis inhibitor, and that is responsible for the hepatic and renal toxicity. And so the gills are wide, and also there is a membranous skirt here and a cup-like structure at the bottom. So this is how you recognize this mushroom. Okay, now let's see another very famous toxin for the liver, which is alcohol. Now, what's the price of using alcohol in our society? This price is really very high. So you can see some data here, which is really stunning. So being an alcoholic person shortens the expected lifespan by about 10 years. So that's usually this piece of information is not known by people. So it's very significant. And this other data is also quite shocking, that about 1/5 of death in people under 70 years of age is related to alcohol consumption in Hungary in some way or other. So that means that many deaths are theoretically preventable. Okay. Of course, this relation to alcohol can be many things. So it could be a drunk driving or whatever. So it's not necessarily related to the toxic effect of alcohol itself. Okay, so what's the problem with alcohol? That it causes a dependency. Okay, this dependency is different from what you see in, let's say, heroin addicts, because this dependency develops very slowly over the years and decades, but it has disastrous individual and social effects. And here you see what kind of toxicity the alcohol has. In this list, if you go through it, you will realize that there is barely a part in our body which is not affected by the toxic effect of alcohol. Okay, so who is an alcoholic? Now that's kind of difficult to say. It's not only the amount of alcohol consumption what is important here, but most of the experts agree that regularity is seems to be even more important. Okay. And how can you find out who is an alcoholic person? That's not an easy thing, because alcoholism is a dependency, and that really affects the brain. So it's not an easy thing. But this is a very, very simple test, which because it's so simple, you might want to learn it, because it's very, very simple. So this is just 4 questions, and 50% of the alcoholic answer yes, at least for 2 of these questions, and 80% of the non-alcoholic answer no for all 4 questions. Okay, so you might want to study this. Now let's see the metabolism of alcohol in the liver. Now, as you learned from biochemistry, ethanol is oxidized into acetaldehyde. And during this oxidative process, we are going to see a change from NAD into NADH. So that causes a change in the redox potential in the liver, and that is going to have a very significant effects. Many of the toxic effects of alcohol are actually due to um, the higher amount of acetaldehyde. Acetaldehyde can be further oxidized in the mitochondria by the aldehyde dehydrogenase enzyme, and that also changes the NADH ratio in the mitochondria. If alcohol consumption is regular, then we expect a significant change in the NADH ratio, and we expect an inducement of many of the enzymes that deal with alcohol, including the microsomal ethanol oxidizing system. So this is the P450 system that I mentioned before. Okay. So, what are the biochemical consequences of alcohol intake? Because of the change in the NADH-NAD ratio, we are going to see some significant changes. So, lactate acidosis occurs a lot more easily. And because the excretion of lactate is um, is related to uric acid excretion as well. So in lactate acidosis, uric acid accumulation is easier. In the cytosol, there is an inhibition of glyconeogenesis. I already mentioned to you that that's why in alcoholic who have a prolonged fasting, they develop hypoglycemia. And in the mitochondria, there's an inhibition of the citrate cycle, and there's an inhibition of beta oxidation of fatty acids, and that's what leads to steatosis of the liver. In the mitochondrium, there is a change in the biotransformation. As I mentioned to you, phase one is increased without an increase in phase two, and that leads to toxicity. But we have also additional changes. So the tolerance for barbiturates in the sober state is increased. So that means if an alcoholic is in the sober state and takes barbiturates for for sleeping pills, they need a higher dosage because the enzyme system that degrades this drug is induced. However, if they take the same dosage in the drunken state, in which case the system is busy with oxidizing alcohol, the same dosage that was good for them in the sober state is going to be really very toxic in the drunken state. So this explains why there are so many drug-induced problems in alcoholic people, and other drugs may be also toxic in alcoholic people. Now, how alcoholic liver disease develops, as I mentioned to you, because of the inhibition of the beta oxidation in mitochondria. The very first thing that happens in an alcoholic person is alcoholic fatty liver, and probably depending on genetic factors as well, and possibly environmental factors, those people who have a long-standing alcoholic fatty liver frequently develop an alcoholic hepatitis. So this is called alcoholic steatohepatitis, or ASH for short. And a long-standing, this could be fatal. So sometimes it causes liver failure by itself. And many times a long-standing chronic alcoholic steatohepatitis can lead to cirrhosis. And cirrhosis can also lead to liver failure. And both of them can lead to hepatocellular carcinoma, which is the worst thing that can happen, because that is usually fatal within 1 year. So, what are the effects of alcoholism on the liver? As we have seen, fatty liver, alcoholic hepatitis, and cirrhosis. Now, there is a dose response relationship. So, the more somebody drinks, the higher likelihood we are going to see the damages. But it is very interesting to see that um, it really depends on the person. So certain people are not very sensitive to this. So it really depends on genetic factors as well, how much alcohol is going to damage the liver. So that is an individual thing. But there is a very significant sex difference as well. So women are about 2 or 3 times more sensitive to the toxic effect of alcohol than men. So you can see this in this figure. So you can see the dose response relationship. So down here, you can see the alcohol consumption in grams per day. And as you can see, if you drink more, the likelihood of cirrhosis is going higher. That happens in both sexes. So the dose response relationship is clear. But I want you to pay attention to the difference in the scale, in the horizontal scale for women. These are women on the right hand side, and for men. So the scale is very different. So that's why women are about 3 times as much more sensitive to the damages of alcohol than man. What's the reason for this? Kind of difficult to say, but probably there's a reason for this caused by evolution. Okay, so this is not really pathophysics, but it's very, very interesting. So maybe I say a few words about this. So in our society, there is a kind of a belief that it's the man who choose their partner, and they choose who they want to marry. But actually, it's quite the other way around. Man kind of um, try to be noticed by women, and it's the women who really choose. And when you want to get noticed as a male, you want to show how strong you are, and for this reason, there is this so-called handicap hypothesis, which means that sometimes men inflict upon themselves really tissue damaging deeds, just in order to show the women that they can deal with the damaging situations as well. So that is probably the reason of those rituals that sometimes were recorded in um, in certain populations, that in certain closed populations, a boy could become a man only if they were exposed to really uh, damaging, tissue damaging rituals. Okay, so this could be the reason why, because this has been going on for a long time, and women didn't have to do this. So a couple of decades ago, it was not customary for a woman to drink or smoke in public. That was not considered acceptable a couple of decades ago. Now it is, which is, fine, because I'm a big fan of equality between, men and women. I support that. But you girls, you should know that there are certain things which are really bad for you. So alcohol consumption seems to be really bad for women. It's definitely, it's not the same as for boys. Okay, good. So, of course, when you are young, you try to be happy, and you try many things. So this is just a kind of a warning from my side, that you want to be careful. You know what you do, and how you live your life. So you want to be careful. Okay. Now let's see the other things that can cause liver damage. So the liver damages that are caused by drugs and other materials can classified into two forms. There is one which is dose dependent. Okay, so this is calculable. Okay, so it's you can calculate what is the dose which is safe, and what is the dose which is not. Okay, so interestingly, there are certain drugs which are really toxic for the liver in large dosage. Okay, so acetaminophen is one of them. So this is being widely used as a antipyretic agent, And if it's used in a very large dosage, it is well known that it's going to cause liver damage. Now, so that's why paracetamol poisoning is the most common cause of severe acute liver injury in the US. Okay, because people don't, keep the rules. So it's printed on the paper that accompanies the drug, that you don't want to use it in larger dosage, but people just don't care sometimes. Okay, so it is also interesting to note, as I mentioned to you, that much less of acetaminophen can be toxic for alcoholics because of this thing that I mentioned to you before, that phase one reaction is faster, phase two is not. And that's why this drug can be toxic in much less of a dosage in alcoholic than in other people. And the other possible drug injury is called idiosyncratic. It's called idiosyncratic because it doesn't happen to depend on the dosage. It happens to depend on probably um, genetic setup. Okay, so sometimes it is really toxic. Sometimes it causes cholestasis. Okay, some more nice birds for you. And now let's talk a little bit about the hepatotropic viruses. Now, there are actually five of them which are really clinically relevant. Of course, we know that there's more, but for instance, hepatitis G virus doesn't seem to be clinically an important one. So here's a nice overview of the five important viral hepatitis. A and E are a little bit similar because they are excreted by the feces, and either fecal orally, as in the case of A, or through contaminated water, as is the case in E, they can infect you. Now, they are also similar in the sense that they never become chronic. So never becomes chronic, E never becomes chronic, at least in immunocompetent individuals. And B, C, and D are different. They are usually either percutaneously or perinatally or sexually transmitted. And that's why they are rather different. D is a very interesting one because hepatitis D infection occurs only in individuals who are also infected with B. Now, this could happen at the same time, which is called co-infection, or at a later time, that's called superinfection. So if those people who are vaccinated against B, they are for this reason also protected against D. Now, we have no vaccine against C. We have a vaccine for many decades now against B. And that used to be a problem for a very long time because that basically means that medical personnel uh, is at a risk for catching hepatitis C because there's no vaccination. And of course, we are dealing with injections, and so it's kind of easy to get infected. So let's see some data about these hepatitis. Sometimes, yeah, what I failed to mention here, so there are two ways to die from a hepatitis, basically. One way is the so-called fulminant course, when the acute event is so bad that you die from it. Now, as you can see, this is pretty rare. Okay. Another way to die from hepatitis is when it becomes chronic. So, and that's why hepatitis C is especially important, because hepatitis C is especially likely to become a chronic infection. Now, what's the problem with chronic hepatitis? The problem with chronic hepatitis is that though these are the people who have chronic hepatitis who are carriers for the virus. So they have an epidemiological significance. And of course, when you have a chronic inflammation, that can progress. So that can that can get worse. And chronic inflammation in the liver can turn into cirrhosis, and either through cirrhosis or directly can cause cancer as well. Okay, the age and immune status also is important. So for instance, when a newborn gets infected with a HBV, then the likelihood of getting a chronic infection is very, very high. So as you can see, this is very different because normally when you get hepatitis B infection, the likelihood that it becomes chronic is fairly low, but that's only true for adults. When you look at newborns, then this is a totally different number. Okay, so let's see HBV infections worldwide. We are having vaccine for something like 4 years now. So that's why there is a very different distribution. So usually you see a high prevalence in those countries which are poor. Now HCV is a bit different because no vaccination. So here the distribution is not so much different. But as you can see in both cases, we talk about hundreds of millions of people who are infected. And for this reason, many, many thousands of people die each year. So here's another case study for you. Okay, get ready with your phones. And it says we have a 57-year-old businessman. He has a history of intravenous drug usage. That was a long time ago, though, and also alcohol misuse. He's known to be infected with HCV. On physical examination, we see pulmonary erythema, hepatomegaly, and you can see the lab values. You can see gamma GT is increased, ALT and AST are mildly increased. Okay, and now let's see the Kahoot questions. Okay. One question that we kind of missed was that may this patient have cirrhosis? And the correct answer is probably yes, but we cannot be sure. So let's see the next question. Yeah, so that's the correct answer. Modestly elevated AST ALT levels are characteristic for cirrhosis. Why? Because cirrhosis is a very slow disease. It's a slow actually it's a kind of a slow inflammation of the liver. And when you have a chronic slow inflammation, it means every day only a few cells die, and it's from the dying cells from where the enzyme can get out. So that's why. Okay, so it's having a relatively mild increases in AST and ALT. They are typical in cirrhosis, and not only at the end of the process, also throughout the whole time. Okay, at the end, of course, the reason could be that we don't have enough liver cells anymore, but also throughout the whole time, they are not very high. Because why? Because the process is slow. That's why. Okay. Ocelot is leading. Okay, quite a lot, but we have still lots of questions. No, lab values cannot really tell you if a patient has cirrhosis or not. You cannot really tell a chronic hepatitis from cirrhosis based on lab values. Now, in the past, people took a biopsy to see if there's already cirrhosis going on in a person, but nowadays you can use a non-invasive ultrasound technique to do that. So it's a special ultrasound technique, and you can use it to measure the collagen content of the liver. Okay. So I don't want to go any further so that I don't mix it up anymore. So let's go on with the slides. So there's a change in the treatment now for HCV. Actually, we have directly acting antiviral agents now, and having directly acting antiviral agents is very good because we can basically heal most of the cases of HCV. So this is a relatively new thing. We have this drug for about 5 years now, and they are very good. Actually, there are several drugs. Several drug companies came out with new drugs. Okay, and this has changed so many things because because of this, because we can actually heal hepatitis C. Now we want to do screening. So screening becomes more and more important. Why? Because many patients are actually infected by HCV and they have a chronic hepatitis, but they don't know about it. So that's why screening is important. Okay, let's see cirrhosis. Now, most of the textbooks say that cirrhosis is a irreversible process. Not exactly. Now we know that because there are certain patients who had hepatitis C viral infection, which started the cirrhotic process. But now that we can cure them, it was seen that even cirrhosis can regress to a certain degree. So it's not totally irreversible. Okay, what can cause cirrhosis? Anything that damages the liver on the long run. So, of course, alcohol is number one in many countries, but there is also non-alcoholic steatohepatitis, which we are going to discuss in a moment. And as you can see, of course, chronic infection and a bunch of other things are also possible. So let's see this non-alcoholic fatty liver disease. Non-alcoholic fatty liver disease is caused by obesity. And since there are so many obese people, there are some estimates that about 30% of the total population has non-alcoholic fatty liver disease. And unfortunately, just like alcoholic fatty liver disease, non-alcoholic one can also progress into a steatohepatitis. So in this case, this is called a non-alcoholic steatohepatitis. And unfortunately, this one can also progress into cirrhosis and hepatocellular carcinoma too. Luckily, it usually takes a long time, and it occurs only in a certain percentage of the individuals. However, since the number of people affected by the non-alcoholic fatty liver disease is so high, that's why still the number of people dying from this is pretty high. Okay, so that's another problem with obesity. Okay, how can you make a diagnosis of non-alcoholic fatty liver? Of course, alcohol consumption should be low, and ultrasound, possibly biopsy, can be used to make the diagnosis. Now, let's see the consequences of cirrhosis. Cirrhosis damages the liver cells, but the effects of cirrhosis are a lot more than just having fewer liver cells. In this picture, you can see a comparison between a normal liver and the cirrhotic liver. So as you can see, there are a lot fewer fenestrations in the sinusoids. There is a lot more fibrosis in the space of this. There are a lot fewer microvilli here in this region. And of course, there is destruction of the cells as well. So for all of these reasons, the effect is larger than the loss of cells. And that's why survival of cirrhotic patients is pretty bad. But this picture shows you that stopping alcohol consumption even at this stage is beneficial. Okay, yet another nice bird for you. And now let's see the consequences of cirrhosis. Consequences of cirrhosis can be caused by portal hypertension or loss of parenchyma or maybe something else. So some things are just caused by the portal hypertension. So for instance, esophageal varices, bleeding, splenomegaly, hypersplenia, and the spontaneous bacterial peritonitis. Certain things are caused by both portal hypertension and the loss of parenchyma, and certain things are just caused by the loss of parenchyma. And there are other diseases as well. So let's see a couple of these things. So esophageal varices are a result of portal hypertension. So because the blood cannot go through the liver easily, it finds alternative ways. And one of those alternative ways are esophageal varices. As you can imagine, this is pretty dangerous because the pressure is relatively high. It's a lot more difficult to access the bleeding site. And the patient may already have a bleeding tendency. Usually this occurs in advanced liver disease, and patients with advanced liver disease usually have a bleeding tendency. Okay, so this is really dangerous. It is only a venous bleeding, but it's a very dangerous one. Now, another another example of uh, portal hypertension is caput medusae. Caput medusae is it's a term that comes from the Greek mythology, so of course we have to mention that. So it looks like this, okay? And I don't have the time now to talk about Medusa, but you can look it up in the Wikipedia, okay? So the Medusa is a very famous story in the Greek mythology. Here you can see ascites can be huge. And here you see what are the factors that play a role in the development of ascites. So there are two major things. One is a decreased albumin synthesis, which causes hypoalbuminemia. And the other thing is the portal hypertension, obviously. So this produces ascites. And because there is a lack of fluid in the normal circulation, there's going to be a secondary hyperaldosteronism, which kind of boosts the whole process. There are a couple of common symptoms of cirrhosis that are good to know. Spider nevus is shown here. Gynecomastia is common in these individuals, and palmar erythema is also common in, especially in advanced liver disease. Advanced liver disease can lead to hepatic encephalopathy, or also called hepatic coma. Here you can see the typical um, the typical signs of it. And there is a very interesting sign called asterixis for these individuals. You want to click on the link and see the video, okay? And how hepatic encephalopathy develops. We don't know the exact pathomechanism, but it is one thing is absolutely sure, that ammonia levels are increasing in these individuals. And because of a diminished urea cycle, this also plays a role. Now, another effect is that many of the patients affected with liver disease have fewer muscles. So the muscle mass is smaller in them. And a decreased muscle mass is also a problem, because there's also metabolism between glutamate and ammonia in the muscle, and that is also lacking in these individuals. Okay, why the coma develops? We believe the astrocytes are damaged in the brain, and this is a slide that helps you to understand what is different in people with advanced liver disease, who have high ammonia level, and between healthy people. So the glutamate and glutamine transformation is different, which leads to an accumulation of glutamine in the astrocytes, and because of the osmotic action that blows them up, and that could cause the brain damage. That is, you can see here. Now, hepatorenal syndrome is an interesting disease. It occurs in patients with chronic hepatic failure. Mortality is very high. What is extremely interesting, that if a person dies in this condition and the kidneys are taken out and they are transplanted into another patient, then the kidneys work just fine. So actually the kidneys are not really damaged. It's just a functional problem, but it's not very clear exactly what is the problem. Okay, so this is the end, and I have a couple of more questions for you in the Kahoot, so please stay and answer the Kahoot questions, okay? And as usual, I want to tell you that the first 3 persons who win the Kahoot should write an email to me, because I have chocolate for you that you can collect, okay? So let's see the rest of the questions. Yeah, so the risk is about the same, because as I told you, women have about 3 times as susceptible. Yeah, so catalase, it was on one of the slides. It's really negligible. So yeah, 20%. So I see you got the message. Actually, that's true for the US, so it may not be true in other countries. Okay. Yeah, of course, that's in Europe, but that's number 1. And now let's see the most important question, the last one that decides who is the winner. Yeah, it's the birds. Okay, so the birds are actually descendants of the dinosaurs. Okay, now let's see who is winning. Okay, congratulations for the winners. Okay, you want to write an email to me to collect your chocolate. Okay, bye bye, guys. It was nice having you here. Bye bye.